First, I just want to thank everyone for attending the sixth panel as part of our Dissemination and Implementation Science speaker series. I'm going to briefly introduce myself, the broader goal of the speaker series, and then briefly introduce our esteemed panelists. So my name is Gwen Lawson, and I'm an assistant professor in the psychology department at Stony Brook University, and I organized this panel and series with the help of Dr. Joanne Davila at Stony Brook, as well as the fantastic members of my lab. And the Dissemination and Implementation Science Speaker Series is part of a project that's funded and supported by the Academy of Psychological Clinical Science. And the overall goal of this project is to strengthen dissemination and implementation science training across clinical psychology training programs. So we know that population mental health challenges have become more pressing across the country and around the world. And there's a real need to ensure that people can easily access high-quality mental health services. And the question of how to meet this need is one that dissemination and implementation scientists have really tried to answer. The field of dissemination and implementation science has developed unique methods, theoretical frameworks, and models that can help move the needle on population mental health. However, training in dissemination and implementation science is not widely available in clinical psychology science programs. So we hope that by making this speaker series free and virtual, that it can support anyone who's interested in learning about the field. So today's panel is called Moving Beyond the Clinic, and it features esteemed panelists, Doctors Lisa Saldana, Courtney Benjamin Wolk, and Gwen Lawson. Each speaker has extensive experience implementing mental health treatments in non-specialty mental health settings, and I'm so delighted for them to be here and for them to present on their important work. So I'm going to briefly introduce the speakers. So we have Dr. Lisa Saldana, who's a senior research scientist and director for the Center for Implementation Science at Chestnut Hill Health Systems Lighthouse Institute. I knew I was going to get that wrong, and then I did. So she can correct me. With a research emphasis in evidence-based practice in public serving systems. Dr. Saldana's work focuses on addressing the needs of families involved in the child welfare system. Dr. Courtney Benjamin Wolk is an associate professor of psychiatry at the Perelman School of Medicine, the associate director of the Penn Center for Mental Health, and the director of mental health implementation research at the Penn Implementation Science Center. And the goal of Dr. Wolk's research is to improve the effectiveness of mental health services for children and adults in non-specialty mental health settings. Dr. Gwen Lawson is a clinical psychologist and assistant professor in the Department of Child and Adolescent Psychiatry and Behavioral Sciences at the Children's Hospital of Philadelphia and the Perelman School of Medicine of the University of Pennsylvania. And her research uses implementation science methods to support the delivery of evidence-based practices, particularly in K-12 school settings. So each panelist is going to speak for about 15 to 20 minutes, and then we'll have a question and answer period at the end. I'll start us off with a question or two before we open it up to the audience. So please hold your questions until the very end. And I also just want to point out that if you have any technical difficulties or you get logged off of the Zoom for whatever reason, we're going to be monitoring the dissemination.implementation@gmail.com email in case you need to reach us. And you can also chat Madeline Papard and Laura Jans, who are here, who both kind of provide you with any technical support. So without further ado, I'm just going to let Lisa take it away.
Wonderful. Thank you. Good morning, everyone, or good afternoon, depending on where you are. It's still morning for me here. So I'm glad to start my, or not start, but end my morning, my Friday morning with you all this morning. Thank you so much for the invitation. As you heard, my name is Lisa Saldana. I'm from Chestnut Health Systems Lighthouse Institute, and I'm going to speak with you all today about some recent work that we have been doing that's sort of brings a whole bunch of, it merges my intervention development work and my implementation science work in the real world as we deliver our interventions to families out in the community. So I'm going to be talking with you all today about Just Care for Families. which is our most recent model that we have developed. In fact, it's so recent that this is not something that you're going to be finding in the literature just quite yet. We have some thought pieces, but just now are at the point where we are analyzing data to be able to put empirical pieces out. But this is of course built on a whole bunch of work that we've been doing for decades now. So to begin with, Just Care for Families is it is a model that is, oops, I'm not sure why it's not advancing. Hang on. What? There we go. But it's backed by rigorous research. So backed by, again, like I was mentioning, work that I've been doing for the last couple of decades around bringing services to families in community settings. We use evidence-based strategies. This particular program, one of the things I'm most proud of, and I'll talk about slightly later, is the fact that it was developed with and for families. And so this was fully developed with an advisory board, a community advisory board of parents who are in need. As you can see here, our model, and I'm going to go into more specifics, crosses a continuum of needs across these 6 different areas. And so we like to think of ourselves, we really are a parenting program at heart, but we are a parenting program with the emphasis on the needs of families who are system involved. And so that very often means severe substance use, methamphetamine and opioid use disorders, mental health disorders. Over 90% of the population that we serve, when they present to us, they do meet criteria for PTSD. And then we are talking about some really basic needs, right? And so documentation, building community, navigating systems. Our interventions are all trauma informed. And as I've mentioned several times now, and sort of the point of why I'm talking about this with you all today, is that when we deliver these services, we bring these services to our parents. So the families that we serve are really any parent. And so some of the previous models that you might have heard me speak about or read about, and even the manuscripts that I offered for this particular presentation, those have always had a very specific criteria of needing to meet a need for a particular substance use disorder or a particular mental health disorder. Just Care for Families really is for all families and all parents where they have a child under the age of 18, where there is, either the opportunity for reunification, or there is a child who remains in the home and we are trying to prevent child placement outside of the home. I have in bold here at the time of referral, because many of the parents that we work with those conditions might be met at referral, but very soon after we are involved with the family, they might lose custody of their children due to circumstance. They do not get kicked out of treatment. And in fact, they are always invited back. We say, once you're in our services, you always get to be in our services. Once in Just Care, always Just Care. And then, of course, Medicaid eligible. So this is a billable service that I'm about ready to describe to you. It's an integrated service, and we really welcome all parents, again, but these are parents who are at risk for child welfare involvement or already involved in child welfare. It is built off of a similar logic model to some of the previous work that we have done, where really on the left-hand side of the model, what we see is what we see very often in the literature are these transgenerational and sort of cyclical natures of child maltreatment and parental substance use. We see that those are very often the contributing psychosocial factors or social determinant of health factors that contribute to child neglect, as well as substance use, are often shared. And so when we have families where they're experiencing both these individual social determinant of health needs, as well as the systemic social determinant of health needs, so challenges receiving equitable services, challenges receiving services where there's not stigma that's attached to them, or assumption that a parent is not going to be able to fulfill those. So there are those challenges in addition to their individual challenges that they're experiencing, like from their own, their own backgrounds and histories. So folks get stuck in this loop. We know, and what the system has told us, is that if we're able to help families receive the recommended or mandated services that kind of cut across systems, We have our treatment services with substance, mental health, and parenting, our social services, and our legal services. That then ideally we're going to see improved outcomes for families, and also improved outcomes for the system. However, what we also know is that it is very hard for parents to engage in those systems. So where we see the little circle here in the middle, that is where Just Care for Families falls. The point of Just Care is to help families sort of bridge this gap and move them from that cycle over to the recommended and mandated services. So we conducted, I'm not going to go through this whole thing, but I want to be able to show we conducted some formative research with parents who had navigated systems before. And some of these families had participated in our previous interventions. You see up here, parent engagement and FAIR. So there was a model that we had called FAIR. Like we still have it, the model still exists. But part of what we learned from parents who had participated in this model was that there were lots of things that they felt could really help amplify their experience with treatment. And it all really had to do with making connections and the things that we are doing out in the community for them, where we are bringing services to them and empowering them to be able to connect with all the different parts of their treatment needs, not just specific to substance use. So that is a model where folks are referred for substance use. But what you see down here, right, you see that that's connected to parent mental health systems, parent sense of empowerment and confidence, unmet needs. And so when we developed Just Care, we took all of this information into consideration. Just Care for Families, it's an outpatient intervention delivered where parents live. Our coaches that I'll describe in a second are available 24/7 on call. And our treatment length is approximately 6 to 9 months. Because we are going to where parents live and where they exist, that means that our coaches and clinicians are going to all different types of environments, rural community homes, urban homes, folks that are living in tent cities, and in other sort of temporary housing situations. We bring our treatment to them. It's a team-based intervention where each family or individual parent is served by a single care coach. The care coach, again, we're offering this out in the community. Some of these are individuals with lived experience, although that is not a requirement. That is something that happens quite a bit. But these are folks that have QMHAs, QMHPs, CADCs, and so certificate type of credentials behind their names. And then they're supported. They all operate as a team, and they're supported by a master's or doctoral level supervisor who provides really, really close supervision. Again, these folks are going out into they're very highly trained, but they're going out into the community. They're going out to these risky situations, dealing with families and the different sort of challenges that they might be experiencing out there in the community. The entire team then is supported with community support. This is a program that leans very, very heavily on our community partners. Again, I'll explain that in a moment, but the team itself has a community access navigator who sort of manages and coordinates all of these community supports. The community supports are necessary as part of our contingency management program. So our circle of service is what we like to call this. It involves these 6 different components. The first, of course, as I mentioned, is parenting. We use evidence-based strategies, parent management training, but we've modified a lot of those strategies to focus more on what happens with the families that we are referred with substance use, where there's a lot more around and less about behavior management needs and more about neglectful parenting needs. And so thinking about things like nurturing and attachment, nutrition, medical safety, proper hygiene, things like that of that nature. We also provide evidence-based, we use contingency management, but evidence-based practice to address substance use. All of our parents who are involved and who have substance use needs participate in treatment every single day for the first 3 weeks of treatment. We are collecting UAs every day, and we are doing a contingency management system with them, while also introducing some very program-specific tools that we use called FITS, functional assessment, sequence of events, etc. And we use a lot of other traditional evidence-based substance use strategies such as, of course, refusal skills, changing environments. We are a very behaviorally based program. For mental health, we use CBT strategies, but those CBT strategies really are couched within a behavioral package. So we are still using our contingency management to help motivate our clients and our parents to engage in those CBT strategies. We are really very much about the here and now and concrete interventions. As I mentioned prior, many of the individuals that we work with have PTSD or have trauma symptoms. We are oftentimes what we do with our mental health is, again, we are only in service treatment with them for 6 to 9 months, which is, while it's a long time, is also a very short time given some of the experiences of our families. So our goal really is to help them achieve stability so that they then are able to go receive more traditional and be successful in more traditional services after we've sort of taken care of their urgent and more critical needs. Again, with the goal being family and child stability. So the other thing that we do is we help navigate systems. Of course, our families are involved in a range of different systems, but many of our parents, when we first meet them, they haven't been to a doctor in years, and they have very serious medical conditions resulting from their substance use or from just the unfortunate circumstances where they've been perhaps, living in an unhoused situation, nutritionally unstable, other things that contribute to our physical health care as well, in addition to, of course, all different sorts of legal and criminal systems. We are working with families really to help build community. This came through to us loud and clear from our community advisory board, is that one of the things that they were feeling most challenged with is the idea of when we change our lifestyle, it means that our peer group changes too. And so really helping folks identify pro-social and positive ways in which they can build connection with others, develop those sort of natural supports, because of course our goal is to not be involved with them forever. And so we want to be able to help ensure that throughout treatment that they are building their own individual supports. And we do that focusing specifically on things that would be really helpful for parents. So engaging with school activities, volunteering for things at your kids' school, things like that. And then finally, our basic needs. You can't get a job if we don't have our Social Security cards, right? We can't, there's some really basic things that we need to help folks obtain: their documentation, food, all of these sorts of things, education. And so that is part of what we do. So all of these components are delivered to an individual, again, out in the community, and by a single care coach, which means that a care coach only has a caseload of 6 to 10 people on their load, because we cover the full county. So it depends on how much drive time you have, basically, is what helps us determine how large of a caseload you have. So for our circle of service, then each parent, we say, would be receiving a minimum of 2 parenting plus at least one of these other pieces of the pie. But some, and very often, our parents are receiving all 6 pieces of the pie. And this is just to sort of demonstrate that all of these different pieces are incredibly important, but they're like sort of the weight and the focus of them in terms of our treatment plan is constantly changing over time. And so it's as we are addressing one goal, then other symptoms come out. It's a very, very integrated approach. And our research has really shown that. We can show from our research that I'm not going to be showing today, but basically how outcomes in these different domains really are influenced by one another. As I mentioned, we use contingency management. And so that is really based off of Care Cash, which is our sort of currency for this particular program. And so, for as many of you probably know, contingency management is one of the only, or is the only, evidence-based practice for addressing stimulant disorders. Methamphetamine is the disorder or the substance that we see most. However, it's also very effective for just behavior change. And so we do not just use it for the substance use component. We use it across all 6 of our all six of our components. And so if you make progress towards, like you did drop off some applications, you get some care cash. If you, try time out with your child for the first time, you get care cash. We are very, very heavy on the care cash, with our message to parents being that right now your job is to engage in treatment, and job is for us to create a healthy, safe environment for your child. So with that care cash, they get to go to the care store with their coach. Our care stores, I have to say, it's one of the proudest achievements that we have. We've done a really nice job, or my team has done, I should say, not myself. I had very little to do with this, but developing relationships with all sorts of businesses, local as well as large national businesses, to be able to stock our care stores. And so they're stocked with both new and donated goods. This provides the opportunity, again, for folks to spend their care cash, but also provides the opportunity for us to do things like teaching budgeting skills, prioritization. How do we sort of leverage what we have here in the store when we have very limited money perhaps coming on our, food cards that we're getting, our SNAP cards that we're getting. So how do we sort of prioritize? This provides the really nice, very low risk opportunity for us to do that, because again, these are donated goods. So if folks make a choice that isn't necessarily the wisest choice, and they're spending all of their fake monopoly money on a donated item that isn't necessarily the best choice for them, there's been nothing lost. But what we've gained is a really big learning opportunity for our families to be able to learn next time when they're using real money at the real store. One of the things that's incredibly important is, again, we are doing this out in the community. And so we are trying to make sure that we are creating an environment that is more reinforcing than substance use. And as you can imagine, that is a really, really challenging thing to do. But because over 60% of our population is unhoused when they're first referred to treatment, that means that our population is very mobile. So we're meeting folks in the community. We need to be really flexible with scheduling. Sometimes folks lose track of what day it is, what time of day it is, where it is that they're supposed to meet us. And so we get to know folks and where they live. We feel very comfortable going out to them. We find out alternate contacts that we can connect with. But then we also do things like, when we show up for every session, you get a beverage or something, a snack. So ways to engage folks. It's really hard to do a session and think about, for instance, your past trauma and work through that if you're really hungry at the same time. And so really helping to meet some of those basic needs with our service delivery. Many of our services involve us providing rides, for instance, to go, like we might be doing our session while we're driving somebody to the grocery store. We'll be providing assistance when we are going and helping them attend court, or providing assistance when maybe we're supporting a parent through an IEP meeting. So all of this is happening out in the community, and these are ways that help us with our engagement. Client sessions, as I mentioned, are quite different from what we see in traditional session. So sort of traditionally in a treatment session, you get your 50 minutes and you have to pack in everything that's happened, sort of come up with your plan and your solution for whatever problem presented itself. And then we see how that happened. We come back our next week. I know that that's not the way all sessions are, but just start at our most basic traditional treatment, versus Just Care for Families, where we're meeting with folks again every day. Sometimes we're meeting with them for extended periods of time. Sometimes we're meeting with them for just a quick visit, just a quick check-in. But what this allows a parent to do is it allows us to work through each of these sort of micro things that are happening before we let anything escalate to the point of crisis. And so we allow parents then to sort of manage their day-to-day stressors in the context of this very large stressor, which is either trying to work their way through the child welfare system or avoid involvement with the child welfare system. I mentioned before that we do this from a very sort of health equity perspective, where we're reaching clients that don't have transportation where they live. We're learning about different cultural practices and values. Here in Oregon, we have a very strong and large tribal community. We have the good fortune and privilege of working with many families from different tribes. And so, of course, there are different cultural things, considerations across the different tribes, in addition to our non-tribal members as well. We partner with all of the systems that we are involved with, but most specifically with child welfare. I'm going to show you in just a second a map of where we have programs so far. Every program that has been developed in partnership with the child welfare agencies in those communities. We work together with child welfare to identify who our actual provider are going to be. And then once those providers are in place, we work constantly. It's just an ongoing relationship between the system and the program. Part of this means that we really need to respect each other's roles and responsibilities, recognizing that we have really different jobs and we have very different relationships with the families that we're working with. But both of us, all of us, are sort of needed to be able to help parents achieve the health status that we're working for. And then, of course, it sometimes takes a few tries. And so this type of treatment, again, we don't have parents who are coming to us, we're going to them. And so sometimes we lose track of parents. And so again, we do not, if once in just care, always in just care. So if a parent disengages from treatment, which does happen more often than we'd like, almost always, and it's pretty remarkable, parents return. And so we like to think of it as just taking a little pause from their treatment journey, and then we help identify ways to motivate their return. All of this is supported by close supervision, of course. One of the things that I really want to stress is that when we are doing work outside of the natural clinic setting, that really, really needs to be supported by very close supervision. So the Just Care providers receive both one-on-one individual supervision every single week. They also receive 2 hours of group supervision with their entire team. That group supervision is then supported by a portal that we have where everybody sort of includes their intervention delivery and the fidelity component. So even I can get on and I can see every single client that is being served across the country right now in Just Care, so that we can sort of monitor for high risk situations, because each of the teams then are supported by a Just Care expert mentor. We use our evidence-based implementation roadmap that I did not talk about here, but that is supported using the stages of implementation completion, which is a different implementation model that my team and I have developed, and we use across many other different evidence-based practices. So just a little snapshot. This is where we currently are present in Eugene, not in Eugene, in Oregon. We currently are in these top 5 counties. We are moving into these bottom 4 counties. And the stats off to the side just are showing that in each of these regions, these are areas that are in really high need. We do not identify the regions. Our state child welfare system identifies the regions. And then again, we work in collaboration with them to move into those counties. As I mentioned, we're supported by our community advisory board, and we meet with them 3 times a year. So I'm just going to thank my team, and I will stop there.
Thank you so much, Lisa. That was incredible. Thank you. So I guess next we have Courtney.
I'm going to talk a little more conceptually and hopefully practically about implementation in non-specialty mental health settings, but I'll try to draw and bring in some examples throughout from some of our work that our team does across some different non-specialty settings. So we're We're doing some work in primary care, in schools, doing some work in emergency departments, as well as in some specialty contexts like oncology. So I'll probably pepper in some examples from some of these different contexts, but I'll largely be pulling from this paper that I published a few years ago with Enola Proctor and Kim Arnold, where we really tried to sort of think about and outline kind of a research agenda around implementation in non-specialty mental health settings, and really try to think about what some of the specific needs are, some of the kind of practical considerations might be, as well as some of the strategies and outcomes that might make a lot of sense to be thinking about if you're doing implementation work in some of these contexts. So so a lot of what I'll talk today about kind of pulls from this article. So I wanted to start by just talking a little bit about what some of the advantages are and some of the reasons are that we think about doing work in these types of settings. And certainly this is not to say that there's not also great need to continue to support implementation in specialty mental health settings, of course, because there's lots of needs there as well. But we think there's some particularly interesting advantages and opportunities to doing work outside of the specialty mental health care setting too. So when we think about some of these non-specialty settings, we're thinking about places where people often are already going for other reasons, for other healthcare services, for their education. So these are places that are generally close to people's homes. They're already spending time there, so it tends to be convenient for them to also be there to receive mental health support. Often they have trusted or ongoing relationships with providers or other folks in these contexts. And there's also important opportunities to integrate some of the services in these contexts with other services that they might already be obtaining. So other healthcare services, educational services, which can give you some nice opportunities to really sort of meet multiple needs potentially in the same context or in a coordinated way that can add value. And some additional sort of reasons why we think these types of settings are important are that we know from research that most people who have a mental health need that is not currently being treated, like many of those people are not going to easily find their way into specialty mental health, like outpatient contexts. We know there's a large proportion of people in need of mental health services who don't receive those services ever in traditional outpatient settings. So if we're only thinking about mental health services and implementation research in those specialty settings, there's going to be a chunk of people who we're going to miss, who aren't going to have access to those services or find their way to those services. And that's for lots of reasons, but certainly we know that there's access issues for many people in terms of navigating the specialty mental health world, finding a provider who takes your insurance or that is cost effective for you to see. It can be really complex to navigate. And also there, and continues to be stigma around mental health concerns and mental health treatment. And for some people, receiving care in other contexts like schools or primary care, it feels like a less stigmatizing place to receive those supports. And people are already using these contexts for their mental health services. So if you talk to primary care clinicians, they often are doing a fair amount of mental health work as part of the larger services they provide. They're often used to treating things like depression or ADHD if they're pediatricians. And they're also used to trying really hard to meet the needs of their patients. And so they're also used to having patients who have struggled to connect with specialty mental health services over the years. And they're already trying to do the best they can to support and kind of meet those people where they are. And, similarly for schools, you have people like school counselors, you might have embedded mental health services, school social workers, you have school psychologists who are already working in these contexts and who who are already kind of touching on some of the things that we might want to enhance through our expertise in more kind of specialty mental health services and mental health evidence-based practices. So lots of opportunities, lots of reasons why we think these are good and kind of important contexts to be thinking about doing this work. But all that said, there are also some really kind of unique multi-level challenges and barriers to implementing evidence-based mental health practices in settings that were not built or designed necessarily to be mental health service systems. Many of these settings might be under-resourced. Often we're talking about settings that rely on public funding and may already be struggling financially. And so adding something to their repertoire, like mental health services, can be particularly challenging or daunting. Financial considerations are often really, really important to think about when doing implementation work in these contexts, especially when you're thinking about implementing evidence-based mental health care in settings that might not have existing billing or reimbursement structures in place for billing mental health insurance. Or might not have additional resources to pay for staff who can be dedicated to do this work or who have this specialty training. So there's often a lot of pressure on these contexts to demonstrate kind of a financial return on investment for anything new that they bring into their setting. And so that can create some challenges, and is really important to understand as you're embarking on this work, like what are the unique sort of policy and incentive and financial challenges of the settings that you're working in, so you can think about how to support implementation, knowing what those are and how you might be able to potentially think about implementation strategies that make sense based on the kind of outer setting context that you're working in. Patient needs and resources are another really important outer setting consideration in non-specialty settings. Complexity comes into play. If you're working in primary care, you might be supporting the mental health needs of someone who also has pretty considerable health complications or comorbidities. Often social determinants of health and challenges, psychosocial challenges might be more pronounced in some of these settings than you might typically see in a kind of specialty outpatient clinic. Not always, it really depends a lot on the specific context, but it's really, we can't assume that these patients are going to have the same kind of needs and resources at their disposal as any other setting that we might work in. And so it's really important to kind of spend some time initially really making sure that we're understanding the unique needs and considerations of the kind of broader context that you're doing this work in. And then kind of drilling down into more kind of inner setting or organizational considerations that might be important to consider when doing implementation work outside of specialty mental health. The sort of like relative priority or competing demands on the time of the clinicians and leaders in these contexts can be quite a barrier. There can be quite a lot of challenges surrounding other initiatives, other activities that people are doing that maybe do not directly align with mental health care. Often there might be pretty significant staffing shortages in these contexts, especially when it comes to staff with actual like specific mental health training and expertise. So it's really important to think about what implementation strategies and implementation approaches make sense kind of based on the structure and organization and resources of the particular organizations that you might be doing this work within. Resources like space, supplies, time can be limited or kind of preferentially allocated. So in some of our primary care-based work, we've had to spend a lot of time really thinking about where are these clinicians going to do therapy sessions in the primary care office. They don't have extra offices to go around. Like they're already scheduling to capacity. And it's also kind of awkward to do therapy in a primary care exam room, right? So how are you going to make that work? What's that going to look like? You have to really think all of those pieces through and really spend time kind of doing a landscape analysis to understand the exact context you're working in. And then because non-specialty mental health settings are often higher need, kind of high stress environments, it's important to remember that kind of support or investment in mental health evidence-based practices might be a lower priority than some of the other services that they're providing. And that makes sense, right? If you think about a school, their primary mission, their primary focus and charge is related to education. And it's not to say that they don't also care about their students' well-being and mental health. And they often see how that interacts with classroom learning and engagement in the classroom community. But still, that is their primary mission and focus and what they need to be paying attention to. And so it can sometimes feel challenging to think about how to also create buy-in to implement interventions that are more mental health related or focused. And there might also be limited opportunities for supervision or time for training and consultation in mental health interventions. And that can absolutely contribute to implementation failure if you can't figure out a way to sort of work within the time and resources that you have available and garner the supportive leaders to create as many resources and time for folks as possible. So making sure that staff will have access to high quality supervision by experts in these mental health practices is often an important consideration and something you have to kind of work through in these types of projects. And then structurally, some of these contexts, when you're integrating mental health into a place that wasn't designed for mental health, there might be multiple organizations involved. So in the work we do in Philadelphia public schools, a lot of the mental health services are provided by contracted community mental health agencies. So the clinicians are physically in the school building, they're working with the students in the school, and they're collaborating with the staff in the school. And they are supervised and they report to someone at their home agency and they are not school district employees. And so that creates sometimes interesting and important tensions or challenges around who needs to be involved in prioritizing this, who are people reporting to, who's supporting evidence-based practices. How do you make sure there's not competing messages about what people are supposed to be doing, how they're supposed to be spending their time? This sort of like interorganizational implementation piece is one that we're still sort of figuring out how best to handle and support. Erin Lyons has done some really nice work in this area, and that might be worth checking out for those who are interested in this kind of tension and concept and kind of what we do about it a little bit more. Information sharing and like privacy considerations also come up a lot in non-specialty mental health work. And so schools are bound by FERPA and healthcare providers follow HIPAA, and those are two different set of regulations. And what information can they share between the mental health staff and the education personnel, and how do they effectively do that when they're not using shared record systems? That can be often something you need to really understand and kind of think through. And understanding kind of the hierarchies and the complexity of the hierarchies, given multiple people and organizations involved, is something that can be sometimes tricky to sort of fully understand, but is really, really important to understand the dynamics of if you want to kind of make sure you're doing everything you can to go in and be successful. And then thinking about some kind of individual, like clinician level considerations. Training is one. So depending on the setting that you're working in, the people delivering sort of your mental health EBPs may be trained mental health clinicians who may come to the table with lots of training and expertise in evidence-based practices and in mental health interventions, and they might not be. They might be teachers, school counselors, primary care clinicians. And so thinking about the pre-service training and what sort of gaps you might need to fill in order to best support delivery of a particular EBP is important. and understanding sort of who the workforce is and what you have access to in terms of specialty mental health trained individuals or not. And then thinking a little bit about intervention characteristics, the adaptability of kind of a certain evidence-based practice for these particular contexts tends to be a really important consideration here. Because the majority of our mental health evidence-based practices were developed for outpatient mental health settings. So the manuals, the way the sessions are structured, don't always fit into the amount of time you have in a primary care office or within the context of a school day where you're trying to see kids within a specific sort of block of time. So thinking about kind of where those mismatches are and how well it sort of your intervention fits or where adaptations might need to be made in order to fit within that setting is important work that has to be done. And if you have a really sort of protocolized, really sort of tight manual that has very specific or rigid expectations around sort of timing and sequencing, is that going to work in this context? It might, and there might be a way to make it work. Or should you be thinking about something that's a little more modular or, engaging in more of a proactive adaptation effort to improve fit before you kind of proceed to implementation? And then just briefly, we also talk in this paper a little bit about what some of the more important implementation outcomes might be to be thinking about when you're working in some of these contexts. And so this comes from Proctor and colleagues' 2011 paper around key implementation outcomes. So as we were kind of working on this paper, Anola and I were thinking a lot about what are the ones that we tend to think are most important to be measuring when we're doing work in non-specialty mental health contexts. And there were several that kind of rose to the top for us. So acceptability, what is the perception amongst the clinicians and leaders and folks in these settings that an intervention is satisfactory? Like, is this a good intervention from their perspective for this context and for their role? And how well does it fit? So that appropriateness piece, like how compatible is this intervention with the organization and the workflow and the training of the providers there? Is it appropriate for the clientele that they serve in this context? Is it going to kind of really meet the needs? Feasibility is often really, really important here. So what's the extent to which you can actually kind of carry this out in this particular context? If it hasn't been done in that context before, that's going to be really important to be measuring and to be looking closely at. Fidelity tends to be a really important one, especially when you're working in a context where the mental health evidence-based practice being implemented is one that's being implemented not by really experienced trained mental health clinicians. So if you're having teachers implement a program or counselors or primary care doctors are doing something and it's not something that's typically been done by that type of provider before, or where the treatment wasn't developed to be delivered by that type of individual before, measuring fidelity and making sure that it's being implemented properly the way it was intended is important. And then cost is always important in our work in these contexts. Everyone is looking to make sure that they're not, as I said, they tend to not have a lot of extra money to work with in a lot of these contexts. And so it tends to be really important for people that their investment in evidence-based practices are at least kind of breaking even, if not yielding some sort of positive return on the organization. And that can be hard to measure, and it can be a pretty high and sometimes unreasonable bar for our mental health EBPs, but it is something that comes up a lot. And then thinking about implementation strategies just briefly. So implementation strategies, as you probably know at this point, are sort of our methods or techniques that we use to enhance adoption or implementation or sustainability of different programs or practices. So the ERIC taxonomy that Byron Powell published on is the paper linked to on the left. And then Clay Cook and others published a version of that taxonomy for school-based research. And so these can be really helpful to reference, of course, as you're selecting implementation strategies. But there's a few that we often see utilized in this type of work in these contexts. And some of these, I think, overlap with what you heard Lisa's team doing, what you'll probably hear from Gwen. But we tend to see a lot of task shifting or sort of revising or thinking flexibly about roles and who's going to do what, and often bringing in mental health clinicians in partnership with community members, with peers, with other individuals who maybe aren't mental health professionals, but have really important and critical roles that they can play in implementation of mental health services and supports. We tend to be thinking a lot about how to promote adaptability. How do we make sure that this practice is relevant, and that it's getting used in the context as we want? Often there can be cross-setting opportunities to bring people together who are doing this work. So thinking about learning collaboratives, thinking about ways you can centralize technical assistance, and thinking about tailoring EBPs to fit the context, and how, if you're working sort of within a broader system, how can you bring people together? How can you be really strategic about those resources and supports? And then just a few kind of additional considerations and sort of future directions as we kind of wrap up. The context is really critical to understand to be successful when working in non-specialty mental health settings, from our experience and from the experience of others. You will absolutely encounter challenges. So staff turnover tends to be really high. There's often confusion around role clarity. As we talked about, lots of competing demands on people's times. And so as much as you can do to be prepared and proactive about those types of things can help you kind of set things up for success. Multiple implementation strategies tend to be the norm. We're often sort of bundling or developing kind of multi-component implementation approaches. And hybrid trial designs tend to be a good fit because while we're interested in implementation outcomes, we're also often interested in effectiveness outcomes, particularly if this is an evidence-based practice that hasn't been widely used in this context before. But there can be some methodological challenges, so it can be complicated to think about measurement and how to structure your analyses, especially when you have those sort of multiple organizations involved. So like if you're measuring implementation leadership, who's reporting about what leader, and do those people even work for the same organization, and how are you going to handle that data? That gets complicated. So we don't always have a lot of clear directions in our field about how to handle some of those tensions, but being really clear and specifying what you do is really important and is really helpful in the field moving forward. So being really clear about the context, who's doing what and how it's working, what are the strategies you're using and how are they being implemented, and what are the different methods you're employing, and being really clear about those. And then as I wrap up, I just wanted to share links to our lab webpage at Penn. If you want to ever connect, always happy to talk with folks. And then we also have our Penn Implementation Science Center, which Brianna mentioned. We have some various educational offerings and things, including a week-long Implementation Science Institute over the summer. So if you're looking for more formal educational opportunities to kind of build on some of the work that is happening in this group and others, definitely feel free to reach out and connect with us.
Thanks so much, Courtney. Great. And then we have Gwen.
Great. Thank you so much. Let me just share my slides. And can I get somebody to confirm those look okay? Excellent. Awesome. Well, I am so glad to be here and to share a little bit about this work where I'm going to sort of take where Courtney left off and zoom a little bit more specifically into the K-12 school setting. So this is my plan for this time. I'll first give you a little bit of background around why schools can be an important context for the implementation of EBPs to support youth mental health. And then even more specifically, why and how I think about teachers as a potentially important part of this work. And I'll lay out some challenges and opportunities to conceptualizing teachers as mental health EBP implementers. I'm then going to talk a little bit about one example project where I'll give you sort of a high-level overview of this project, but really my goal is to use it to illustrate 3 key takeaways about what I think we learned about what's important to consider as we are using teachers as mental health providers. And I'll end with an overarching summary. I'll say up front that this work was supported by a K-23 from the National Institute of Mental Health, although the opinions I'm sharing are my own and don't necessarily represent NIMH, and I don't have any other conflicts of interest to note. And then I'll just show you the learning objectives for this talk in particular. By the end, I hope that you'll be able to describe the role of teachers really as important professionals in promoting positive youth mental health outcomes, and also identify some barriers and facilitators to implementing EBPs in school settings specifically. So why should we care about mental health services in schools? I think Courtney laid this out nicely with the idea that most youth in need really don't ever actually receive mental health services. And when they do, schools are one of the most common places that they do receive them, to the point that schools have sometimes been referred to as really the de facto mental health providers for youth. And this is particularly true often for low income or racial ethnic minoritized youth. I also want to highlight that there really has been a lot of interest in school mental health in the past several years. So these are data from a survey called the School Pulse Panel, which was run by the National Center for Education Statistics. And in the 23-24 school year, 84% of public school respondents indicated that they provide some kind of individual mental health intervention for students. And 58% of schools indicated that they've seen an increased student demand for mental health services that year compared to the previous year. So there really is a lot of interest and attention and perceived need for mental health services in schools. And then just to sort of set the groundwork here, often people think about school mental health services using this sort of multi-tiered systems of support framework. So the idea is that there can be tier 1 or universal services that every student in the building receives. These could be things like sort of common school-wide expectations or classroom-wide socio-emotional learning programs, and everybody should be getting them. And then for students for whom that's not enough, they can also be receiving tier 2 or sort of targeted or early intervention services. So these might be things like a time-limited social skills group. And then at tier 3, a smaller number of students can receive more intensive and more individualized supports. So I think this sort of fits nicely with probably how a lot of us think about the sort of public health model by which we can be addressing mental health needs at a population level. So I think there's a bunch of really important opportunities to providing mental health services in schools, as well as a number of very real challenges. And again, I think sort of Courtney laid this out nicely across many non-specialty settings, but I think many of these considerations are definitely there in K-12 schools. So schools are an accessible place for kids to receive services. They can minimize, in many cases, many of the barriers that come with getting to a clinic setting. They're also naturalistic. This is where youth spend many of their waking hours. So there can be, potential opportunities there to be receiving supports kind of where they actually are spending their time. There can also, I think, be important opportunities for engaging teachers and other important adults in kids' lives. At the same time, like Courtney said, schools have a primarily educational mission. So that means that they rightfully so may really sort of not view mental health as within their primary mission. And there's been an argument, I think, for a long time that those of us as mental health people really need to acknowledge that, and we need to do our work within schools fitting in with that reality. Any of us who've spent time in schools also know they are busy places. The competing demand considerations are very real, often very high levels of staff turnover. And that can create real implementation challenges, particularly if we're thinking at all about asking anybody to take on anything new. I also want to acknowledge that I think many of these challenges have been particularly salient in recent years. So we sort of have this interesting context where there's a lot of interest and excitement about the potential of school mental health. And also schools are facing very real financial and staffing challenges. And, I think we, again, need to be considering both of those things as we're thinking about this context as a place for potential mental health intervention. So again, Courtney, I think, set us up nicely with this idea that there can be many barriers and facilitators across contextual levels and non-specialty settings. As one way we've thought about this, and this is specifically to barriers and facilitators to the implementation of Tier 1 and Tier 2 services in K-12 school settings. Here we use the EPIS framework to organize contextual levels, but a lot of what we were seeing in this qualitative project that's in progress is very consistent with what we've been discussing. So within the individual school, things like alignment with school culture, the level of staff supports and teaming, the availability of training and technical assistance as really important factors. And then also at the outer contextual level, thinking about funding, about sociopolitical climate, about priorities of state policies and school boards. And then as these partnerships with external agencies or collaboration across districts as factors that can potentially bridge the inner and outer context. And then finally, this idea that factors at the individual intervention level are really important, and things like how appealing and how easy is it to use are people talking about these as important barriers and facilitators to implementation. Okay, so everything I've laid out so far has really been about K-12 schools as a setting for mental health intervention. But I would also argue that we should also be thinking about specifically the role of teachers as potentially really important individuals here. Teachers really matter. These are a couple examples of papers that sort of demonstrate the impact that teachers can have both on student academic outcomes, but also actually on student social and emotional outcomes. So I would argue that in the same way that we can think about parents and caregivers, really, we can probably conceptualize them as part of the mental health workforce, broadly defined, that these are people who can have huge impacts on children's social and emotional and behavioral well-being, which is really their mental health. I would argue that we can also think about teachers that way. And I also want to acknowledge that we as society put a lot on teachers. So I think anything we're doing in this context, we really need to be starting from a place of respect and acknowledging teachers' expertise and autonomy, and really thinking carefully about what they see as their roles, so that our work can ultimately try to make their jobs easier, not harder. So let me zoom in a little bit to one example project, really with the goal of using this to illustrate a few takeaways about how I think we can approach this work. So the goal of this project was to develop implementation resources to support teachers in using behavioral classroom interventions, which are an evidence-based practice for students with or at risk for ADHD. And we did this work across 3 stages. In the first stage, we used mixed methods to examine barriers and facilitators to teachers' implementation of these practices. And then in the second stage, we worked to iteratively develop these resources. And we did this in partnership with a team of educators and through an iterative process where we got and incorporated feedback from teachers as they used them. And then the third aim was a small scale pilot RCT that we did conceptualize as a hybrid effectiveness implementation trial, because we were interested in both teacher implementation outcomes as well as student effectiveness outcomes. So just to give you kind of a high level overview of what these resources are, what we ended up calling them is the Positive Behavior Management Toolkit, or PBMT. And it really has 3 core components. The first is a resource library that's available both written tangibly and online. That includes things like written materials, like sort of very simple one-pagers or fillable planning guides, as well as videos with things like teacher testimonials about their experience using the key interventions, as well as tangible resources, really with the goal of making these interventions easier to use and make part of routine practice. The second core component is optional text message reminders. And then the third are brief meetings with the consultant that are really framed around sort of helping the teacher navigate this toolkit and use it to work for their priorities and their goals. So the toolkit's organized into modules that's aimed to support first 4 specific behavioral interventions, which are considered evidence-based intervention for ADHD. So these are things like behavior-specific praise that are evidence-based for ADHD, and then 2 additional modules focused on strengthening the student-teacher relationship, as well as the teacher's own wellness, which we included because we had identified those really as important implementation barriers and facilitators in and of themselves. All right, so I want to use this project to share 3 takeaways of what I think is illustrated about how we can consider and when we can and should be considering teachers as mental health EBP implementers. And the first is really about alignment with their roles and responsibilities. So I'm just going to put some words up on the screen. And as you look at these, I imagine that you're thinking that probably some of these feel more aligned with teachers' roles than others, right? Teachers aren't therapists. They don't have that training, and there's actually a lot of data out there that they're really not particularly comfortable doing work that is conceptualized like as strictly mental health, right? Like that is not their role. But in most cases, teachers really do see classroom management or positive behavior management as very much within their training and their expertise and what they see themselves as doing in the classroom every day. So I think what that means is that we can be looking for opportunities where mental health EBPs do in fact align with teachers' roles. And in this project, we did this by thinking about EBPs for ADHD. So this is an article that's sort of reviewing what are the evidence-based psychosocial treatments for kids with ADHD. And one of the treatments that they concluded is well established by the evidence, particularly at the elementary level, is what they called behavioral classroom management interventions. And really what this means is just teachers using positive antecedent and consequence-based interventions in the classroom. So sort of similar to what we teach parents and caregivers to do with behavioral parent training. And they concluded this is well established for kids with ADHD. And then the second article lays out evidence-based intervention for ADHD across that multi-tiered framework that I showed you earlier. So this is the table from that article, and what it highlights for me is at tier 1, there's things like labeled praise, having sort of clear expectations in the classroom. At tier 2, one of the main evidence-based interventions is something called a daily report card. And I put these red boxes around the interventions here that I think fit pretty squarely into that behavioral classroom management bucket. So these are well established for ADHD. But what I think this table highlights is a lot of these interventions are actually tier 1 interventions. So that means that they're things that potentially all students in the classroom can benefit from. And these are also things that teachers typically do think of as part of their job, but they might not really conceptualize it as evidence-based intervention for ADHD. They may be more thinking about this in these terms of classroom management or positive behavior management. So I think this is a case where if we can capitalize on that and really frame this for teachers in the words that they use, around the things that they do see as within their roles and expertise and responsibilities, then this may make a lot more sense. And then beyond that, I also think the fact that many of these interventions are in fact tier 1 interventions offers the potential opportunity that if we can help support teachers in implementing these for students with ADHD, but also for the whole classroom, it may just help the classroom run more smoothly in general, which could potentially help make teachers' jobs a little bit easier if they can be doing some of this for everybody, not just thinking about what they have to do differently for each of the 30 different kids in their classroom. So the way we tried to do this with the positive behavior management toolkit is first, the whole thing really is framed around positive behavior management. It's not sort of billed as EBPs for ADHD. We also developed it to support these specific practices, that we use terms for these that teachers are more familiar with and that teachers are more likely to think about kind of as these classroom management strategies that they can be using for everybody. And then also do acknowledge that many of these interventions really can be used at the tier 1 level. So even though this is meant to support their work with focused students with at risk for ADHD, they can also be thinking about how they're using this with others or with the whole classroom as well, if that's what they want to do. The second takeaway I want to highlight is, again, the just incredible importance of contextual appropriateness in schools. So we know that schools aren't clinics. They have a primarily educational mission. They operate on sort of a very set school year schedule, and often have really unique school day schedules. So as we develop interventions and implementation strategies, we certainly need to be considering those things, doing things like making sure that trainings fit within school PD days, thinking about consultation models, sort of fitting within teachers' planning periods, all of that. And I also think beyond that, we can be thinking even more about school-wide systems and structures and making sure that the work that we're doing is fitting within them. So one way that we tried to do that in this particular project was thinking about a model called School-Wide Positive Behavior Interventions and Supports, or PBIS, which is a multi-tiered framework that many schools use across the entire school building to support student behavior. And there's a lot of different components to PBIS, but in the classroom, if a teacher is using practices aligned with PBIS, what it really looks like is a lot like what I'm talking about with behavioral classroom management interventions. Having clear expectations and norms, acknowledging appropriate behavior. So there's a lot of similarities with this and the sorts of EBPs for ADHD that I might be thinking about. And what that's meant in this work is that we've partnered closely with folks from the school district PBIS team, and to really think about what training and what supports are they providing, what terminology are they using, and how can we frame this work in a way that fits within it so it can be seen as an additional support within a PBIS framework if that's what the school is using, rather than something different or competing. And then the third takeaway I want to highlight is just the importance of really centering teachers' perspectives and voices throughout anything we're doing in our work. So in this case, as we developed the positive behavior management toolkit, we did this through an iterative process that's described in a lot more detail in a paper that's linked here if you're interested in taking a look. But what I'll say briefly is we worked with a team of educators that, in this case, we called a program development team, but very similar to an advisory board. And we got their input from the very beginning. And then we also tried out versions of this with teachers, had them use it, asked them for their quantitative and qualitative feedback. And we did this a couple of times. And each time we then analyzed the data, discussed it with the PDT, and used that to make revisions and improvements to the toolkit. And I think it was really important that we took our time doing that and really got meaningful input throughout the process. And this is something that we're hearing now. This is a quote from a teacher who used it later. And I think what it highlights is that, they really valued knowing that educators' voices were in this from the very beginning, and were very much sort of part of it in a meaningful way, that was something that was helpful as they engaged with it later on. So just to wrap up, here's what I hope I've convinced you or you'll take away from this. First, that schools really can be a setting where we can be supporting child well-being and mental health, but we need to acknowledge that they are not clinics and they're not supposed to be. And second, that teachers are people who can be implementing EBPs for child mental health, but again, they're not therapists. And so given that, I would argue for the importance of making sure we're being really careful about selecting and aligning our evidence-based practices with teachers' roles and responsibilities, and doing this in a way that can be potentially decreasing rather than increasing workload. Second, that we're thinking carefully about contextual appropriateness in K through 12 schools specifically. And then third, just the value of centering teachers' voices. So I will end there and pass it back to Brianna if we have questions.
That was excellent. Thank you so much, Gwen. Thanks so much for those wonderful presentations. Those were all really informative and really dovetailed nicely together. So before we open it up to the audience for questions, maybe I'll just sort of open up with more of a reflection, but curious if you all just sort of want to speak more about this. So, you all kind of made the compelling case that we're sort of moving beyond these sort of specialty mental health clinics, in part because first, people's needs are connected, as Lisa really showed compellingly, and also that we want to meet people where they are. But you also all really highlighted some of the tensions of that, both like logistical, organizational, and also I also heard some ethical challenges around information sharing and what it means to serve multiple roles. And I'd be curious, like, thinking about all of these presentations kind of together, especially, I'm thinking about the child welfare system and like trust and just if you had further reflections on that tension that you wanted to speak about.
I can just comment briefly on the child welfare system and then kick it over to my colleagues for the school system. Yeah, I think that you're right. One of the things we have a saying that's, I'm sure some of you have heard this before, but nothing about you without you. And so we have a very clear sort of not just ethical policy, but as part of our procedures for what we do in terms of at intake, we really get a wide breadth of release of information, right? But then we continue to build that repository over time, over the course of treatment as we get connected with different places. And it's important. We went through this even just yesterday. We get this wonderful donation from the county parks. They're saying that they, like we can get passes for clients, but of course we have to give client names for that. And of course the county knows that they're reaching out to us because we offer a service. So if we give the names, they know that those folks are in treatment. And so how do we handle that? And so coming up with really communicating strongly with that partner to develop an ROI type of situation that will work for our parents. I mean, it's always kind of thinking creatively. The supervisors who come into this role talk about that being one of the greatest challenges, Brianna. So I think you picked up on something really big there. It seems small, but it doesn't operate like a traditional clinic where you have somebody come in, you have an office receptionist who's, having an intake packet. And so those are the sorts of things that when you're out in the community, we do have to balance, but I've never found a challenge that we were not able to overcome. With that, many challenges we can't overcome, but with coordination of the services, yeah.
I think Lisa laid that out really nicely. I think you do your best to sort of anticipate what some of these potential ethical or regulatory quandaries might be as you start embarking on this work and preparing for implementation and developing your protocols and your plans. And there's always going to be something that pops up that you hadn't thought about or that's different than what you prepared for. And so that's where I think having really strong ongoing partnerships and open communication with your partners so that you have, a mechanism in place and people to go to really sort of talk it through and hear all the different perspectives and come to a solution that works for everyone is really important.
Yeah, I agree. I don't think I have anything to add to that.
Thank you all. You all are just doing such incredible work and sort of thinking creatively about how we can sort of expand the reach of support and care to people. So really appreciate your efforts. I wanted to just, I'll hold off on more questions that I had. I was jotting some things down as you all spoke, but just open it up to the audience and just mention really briefly that we are recording, as you probably know at this point. So if you don't want your face on camera and on YouTube, I'm happy to read out a question if you want to put it in the Q&A, but you can also use the raise hand function in Zoom to ask any questions and we'll just unmute you. Or alternatively, while folks are thinking, I guess I'm curious about just talking a little bit more about something that was also kind of a tension or a dialectic across the talk, sort of like when you decide to sort of think about um, non-mental health professionals themselves as the implementers versus when do you bring in a mental health professional into a non-mental health setting? And I guess was curious about sort of how you think about that, Gwen. Your talk really spoke about that. And so I loved the sort of tiering idea as like, a decision tree or logic, but was curious if others had thoughts.
Yeah, I guess my immediate reaction, and I'm curious what the rest of this group thinks, but like I don't think of it as an either or thing, right? Where I talked about this project where I'm saying we can conceptualize teacher as the implementer and they can be doing this at tier 1 and tier 2. That doesn't mean that a child in the classroom with ADHD shouldn't also be getting sort of more specialty intervention for ADHD, which could also include sort of more specialty consultation with the teacher than what this model is. So yeah, I think ideally we can think of it as both, but we also know that that's not going to happen across the board, which I think is where some of that more tier 1 and where can we sort of conceptualize the non-mental health providers as people who can still be supporting youth mental health. But I'm curious what the other two think.
Yeah. Well, Courtney, do you want to go if you're going to stick in the mental health, in the school setting? Because I'm going to hop.
Sure. All I'll add to what Gwen shared is that I think like the role of clinicians, there's always some role for clinicians when you're talking about mental health practices and people with unmet mental health needs who are being served in these contexts by whatever it is that you're doing. But what role they play, I think, just depends on exactly what you're doing and who the different individuals are that are involved. So they might be doing weekly supervision with the peers or the teachers who are the ones kind of on the ground implementing. They're probably providing training. It might be more hands-on or more sort of coordinated care. I think it just really depends on the specifics, but there I think often is some important role for trained clinicians, regardless of who's doing the kind of direct implementation of the intervention.
Yeah, and I would just say that what my response is going to be very specific to our intervention, but I do also think it probably applies more broadly. And that is that those decisions very oftentimes for us are determined by the system. And so when I was first developing these programs, I was so certain I was going to hold firm and fast, right? That we were not going to have parts of the intervention or part of the treatment that a parent needed delivered by somebody outside of our team or somebody who, is more traditionally trained. Because part of our goal is to not have parents be overwhelmed. They have all these different services to go to. We don't want to overburden them. We want them to engage well, yada, yada, yada. All of that, I think, theoretically sounds really great, but when you have a judge saying we're not going to return a child unless a parent receives a service from somebody with X number of credentials behind their name, we're not going to get in the way of that. And so one of the differences between this model, Just Care, as well as others, is that this model really embraces that we need to be considering in treatment planning the perspectives of all of the partners, and the criminal legal system and child welfare legal system is part of that. And so although those might not necessarily be what we would think of as our treatment targets, our ultimate treatment target is family stability. And so if that's what we need to do to accomplish that, then we will work in partnership with those decision makers to make sure that we're getting those needs met. I don't always think that means that our team can't fulfill those roles, but because we don't meet the box that the judge wants, we will allow somebody else to do that again, because that's what's in the best interest of the parent.
And I'll just put in a plug really quick. The paper's not out yet, but we're close to having a paper published that I'm working on with Sam Rushworth and Emily Becker-Hames and Tori Creed and some others at Penn that's around ethical decision-making and problem-solving around in community-based implementation work. So it touches on some of these things in there. So it's not out yet, but I can certainly share it with you, Brianna, when it comes out. And maybe it'll help be a useful resource for some of these things too.
Yes, definitely. I'd be super interested in it, and I'm sure some of the audience members would be too. There's so much also to ask about like financing. I was like so excited about the Just Care model, sort of like, just in time approach. And I know Courtney's done a lot of really incredible work sort of highlighting the need for collaborative care to be incentivized and financed. And so I'll just sort of tease that as like things for the audience to look at just for the sake of time. I'm gonna just sort of wrap us up now, but I just want to send another kind of virtual round of applause to our wonderful panelists who are doing really amazing work on the ground and for sharing the insights that you have from that work.